Good evening and welcome all delegates to this first ever ISAR Global Impact Factor webinars. So we are starting this webinar this year from 2022 to 23 to 24. Every month one program. And first and foremost, I would like to invite our ISAR President, Dr. Nandita Palshetkar. Can I have her CV, please? I would like to invite her to give a short introduction. Dr. Nandita Palshetkar's CV. Yes, to give a short introduction to this academic program that ISAR has planned throughout the year. So Dr. Nandita Palshetkar needs no introduction for the members of ISAR. She's the president of ISAR at this time. But still it gives me a lot of pleasure to introduce and speak a few words about her. She's been an eminent IVF specialist for almost 30 years and worked in many centers, mostly Bloom IVF in Mumbai, but many other 7 centers all over India. She has pioneered in many latest technologies of ICSI, laser hatching, blastocyst culture, spindle view, IMSI, in vivo vaginal cultures, metabolomics. In fact, her center is one of the first in the country to get many of the latest advances. She's a PG teacher. She's delivered many orations, more than 70. She's authored many books and chapters. And mostly she has been a president of almost all societies in our country. So she's very experienced in leading ISAR in the present endeavor. Many awards that she has received. The most important, I think I would like to speak of is Bharat Gaurav Award of 2014 in the House of Commons in London, and Frost & Sullivan Best IVF Service Provided Company of India in 2013. Other than that, she has many achievements to hand. So I'll invite Dr. Nandita to give us a short overview of this program.
Thank you, Sujata. Thank you very much. I think first of all, welcome to all my ISAR family. It is a great pleasure, and I think it's one of the best presidencies of my life, I think. ISAR, I mean, IVF is my passion, and I'm so happy to be leading this organization where everybody is so passionate about infertility. And, you know, having taken over post-COVID was something that was really beautiful that happened. Because today, we have the best of both the worlds. We are having the webinars and we are having the physical meetings also. In fact, if you see today, we have one of the best speakers. We have some of the international people who come and who talk to us, and we can do really multiple programs and different kinds of activities which were not possible unless we spent a lot of money before, you know, in flying the people down and all. And also there was no problem in flying people down, but the time, the effort, and sometimes the availability became a problem. So I think today, as I took over ISAR, the vision that I had multiplied many-fold because of this effect of the, you know, the opportunity that COVID gave us of holding webinars and physical meetings. So this program today, the Impact Factor, which we have launched, was something that, is, let's say, you know, we were thinking about it. There's so many papers, so many articles, and so many controversies that happen in our IVF, which are very important to be discussed. And then we quote papers. And so what we thought was, Sujata and myself sat down together and we identified some really, hot topics, some common topics, something that would be useful in our day-to-day practice. We identified those topics and we got in touch with the people who have published something latest. You know, all these publications and all these scientific researchers have done latest work. This meta-analysis, which we are going to discuss today, my friend Louis Alonso is here, and we are going to discuss this paper, which is very much talked about and which is something which we would like to know what to do in our practice and what the evidence says. Because friends, today we have the ART law and we need to do evidence-based practice. And I think it's very, very important to understand what that paper actually tells us, because sometimes, we don't understand in between the lines and what the limitations of each study are. And I think the author who has done the review and the systemic review and the analysis, the meta-analysis, will be able to throw light. I think that is the best thing that can happen. And this is what we want to bring to your doorstep. This is the first in our series. And I'm really happy that Sujata has worked very hard. And we are happy to have our president-elect, Vice President Sunita here. She's always been very supportive of all my activities and a dear friend for so many years. And of course, the young one, Ekika, who is driving our managing committee member. This time I have a very vibrant managing committee, which is really very gung-ho about helping all of us. And I think the whole idea is that everybody works together and each one is helping out with one impact factor. I think Sujata and me have really taken it that we will involve each managing committee member to participate in it. So I think I will, Sujata, thank you very much for giving me this opportunity, I think, to talk to the people. And I'm sure we will put this online also on our website and YouTube channel so people can access it. And we broadcasted it to all our ISAR members. And I'm sure we will put it even in the Foxy groups, because this is something that people definitely want to know and all OBGYs will want to know. So maybe we can actually put it across all over the country and maybe all 40,000 gynacs can access it. So Louis, we are really looking forward to a fantastic discussion. And I'm so happy that you are here with us. I know it would have been so much more fun if you were here physically, but this is also equally good. And I'm really happy to have this interaction. Thank you. Thank you very much for all of you all, and especially the delegates and the participants for being here to, enhance the beauty of this program and the scientific and the academic knowledge that we shall gain from today's function. Thank you.
Thank you so much, Navita. I really hope that the delegates and all enjoy, and we have lots of question answers after Dr. Alonso's talk. So I would now next invite Dr. Ekika Singh. She's our executive managing committee member. She's a fertility consultant and she's working at this time in Sharda Narayan Hospital and very, very academically inclined. So Ekika is going to give us a short summary of the abstract of the topic or all of the article that we are going to discuss, the meta-analysis. So Ekika, go ahead.
Yeah, okay. Thank you, ma'am. And first of all, a very good evening and warm welcome from the whole ISAR team. So the article we are talking about is about effect of hysteroscopic metroplasty on reproductive outcome in women with septate uterus. It's a systematic review and a meta-analysis. Dr. Lewis, along with other stalwarts, reviewed this article. So I'm going to present a small abstract and a basic highlight of the article. The aim of the review is to evaluate impact of metroplasty on adverse reproductive outcomes like miscarriage, preterm delivery, fetal malpresentation in women who has history of infertility, bad obstetric history, even the women without previous pregnancy failures, but if they have been diagnosed to have a septate uterus, are also being included in the study. So the whole data was collected from various sources on PubMed, Medline, Embase, Cochrane Library, Google Scholar, trial registries, and various keywords were used to retrieve the data. And what was taken? It is the studies which compared reproductive outcome between women undergoing hysteroscopic septal resection and the women who had expectant management. These were the studies which were included. So there were total 1,076 studies which were retrieved. But out of those studies, only 11 studies were included after excluding all the duplicates, screening the abstract, and even assessing the eligibility. So out of these 11 studies, one was RCT and the rest 10 was observational studies. And this all included near about 1,580 any partial or a complete. So these three subgroups are taken, and the OR ratio in all these three subgroups also showed reduced risk. In complete, it was 0.16, partial 0.36, and the studies which didn't show any difference was also 0.58. So in a nutshell, when it comes to miscarriage, they showed there was a reduced risk of miscarriage when there was a septal resection. Now, similar result was seen for preterm delivery and malpresentation. So, but there is a thin line. The reduced risk was seen only when the partial septum resection group was studied, and the OR was 0.30 for preterm deliveries, and for malpresentation it was 0.32. There was no difference seen when this preterm adverse outcome was studied for the resection of complete septum, or maybe in the study when there was no difference. Beside this, there was no difference between clinical pregnancy, term live birth, or risk for LSCS in these groups. So after the analysis, the whole analysis supports hysteroscopic metroplastic dissection effect, or maybe they say it is effective in reducing the risk of miscarriage in patients with partial or complete septum. But this data should be confirmed with all other well randomized control trials, because as we saw in the study, there was one RCT and 10 observational studies. So that's the nutshell of the abstract. And over to you, madam. I think we need more light on this by Dr. Lois.
Thank you. Thank you, Ekika, for giving us a short review. So now I would like to invite Dr. Louis Alonso. Can I have his CV, please? So to talk about his study and to compare it with the other studies that have been published. So Professor Louis Alonso, he's an obstetrician gynecologist. He works in the Centro Gutenberg. Apart from the fact that he was earlier he was the chairman of the Global Community of Hysteroscopy, executive board member of the European Society of Gynecological Endoscopy, and he is the immediate past president of AAGL Hysteroscopy SIG. But I know him, and I think many of us know him as the main editor of the Hysteroscopy newsletter that we not only get as being members of the Global Hysteroscopy group, we get on our emails, on our apps, but also on Instagram. All those who follow Hysteroscopy newsletter, we really enjoy it, Dr. Louis. The guess what, and the such beautiful pictures you post. I'm sure they're all your personal pictures. I simply enjoy those newsletters. So all of the delegates who are on Instagram and not following Hysteroscopy newsletter should be doing that ASAP. So I invite you, Dr. Louis, to give your talk.
Okay, thank you. Thank you very much for the welcome and for the invitation. And it is an honor for me to be here, to spend some time with you and to share this lecture and this topic. Let me share the screen. Here it is. And this is the dilemma: to cut or not to cut, do something or not. And you know, every time I have a lecture about this decision, I really don't know if I am the right person to give an answer, because I am really biased, because I am reproductive surgeon. I do my own 3D ultrasound. I do my own preoperative evaluation, and I work closely with IVF units. So I mainly work with patients with bad reproductive outcomes and or infertility. And what I see after the surgery is that the results are much, much better. You know, so what I know well is that I'm really confused about what to do, about the recommendation of some societies, about the management of this pathology, about the papers that you can read. So, you know, sometimes it's really difficult to go through the right way in the management of this uterine malformation. So things that make me confused: the diagnosis, because the first step is to have a right diagnosis. But when we talk about septate uterus, Are we using the same language, the same here in Spain, or there in India, or in the USA? You know that we can use different tools in the diagnosis of a septum. We know that not all of them are really accurate in the diagnosis. The most accurate are combined hysteroscopy plus laparoscopy, but we are talking about the surgery inside the tummy, with maybe we can have some complications. So it's not a good tool for the diagnosis. The 3D ultrasound and the sonohysterography. For me, the 3D ultrasound today is the best tool that we can have for the diagnosis, for a right diagnosis of this pathology. But also we can find, when we talk about the surgery of the septum, we can find different type of septum. Some are broad, some are thin, some of them have more muscular component, some of them are complete while other are partial. So we cannot talk about the surgery of the septum because there are different types of septum and everyone has a different approach and a different kind of surgery. And last, there are several classifications. The most commonly used all around the world is the one by the AFS, the American Fertility Society of the 1998. So it's something really old, was based on the result of the hysterosalpingography, sorry. And sorry, I have some problems. Okay, and it is an old classification based on the result of the hysterosalpingography. Recently, we have the one from the ESG-ESHRE from 2013, and the latest one from the ESRM 2021. We have different classification. They are not exactly the same, and they classify the septate uterus in a different way. So that uterus that is a septate, for example, for the European one, is not a septate for the American one. And that's a problem because we are not treating exactly the same pathology and we cannot have the results, exactly the same result or a global results. So the second confounder problem that we have is the reproductive impact. We know that septate uterus is associated with infertility, with recurrent miscarriage, and poor reproductive outcomes. I want to share with you this interesting paper by Sotilio Sarvelos about uterine malformation and reproductive impact. Using accurate diagnostic tools, you can see there that we can find an incidence of uterine malformations of 6.7% in general population, in infertile patients, 7.3%, and in patients with recurrent miscarriage is 16.7%. So there is a link between uterine malformations and infertility or recurrent miscarriage. But if we look at the 4 meta-analyses published about this link, we find differences between them. The top of the scientific evidence today is the meta-analysis, systematic review and meta-analysis. And when we have one of them, we have maybe the top of the evidence. But the problem is that if we do 2 meta-analyses about the topic, we have differences between them. And if we have 4 meta-analyses about the same topic, we have disparities between them. So one question that I throw to all of you, we have to discuss about if the meta-analysis and systematic review is the top of the evidence. Probably no. So regarding the septum and those 4 meta-analyses, they only agree in one thing, is that canalization anomalies has been consistently associated with increased risk of miscarriage, as you can see in the 4th of the meta-analysis. And the rest of the thing are different. And there are differences between the result of the meta-analysis. So we have to check and we have to discuss about if the meta-analysis is the top of the evidence today. Regarding society's recommendation, we have the same problem. By one hand, the American Society of Reproductive Medicine, and in relation with this topic of the septum, they have only one paper. It's a paper for 2016, so it's an old one, in which they state that in patients with infertility, prior pregnancy loss, or poor obstetrical outcome, it is reasonable to consider septal incision. So ASRM is pro septum incision in some cases. But if we move to the European one, this is the ESHRE guidelines. They have different groups and different special interest group. And the only group in which we can find some data about the septum and what to do is not in the reproductive surgery group, but in the recurrent pregnancy loss one. And they recommend to check the uterine anatomy to all the women with recurrent pregnancy loss. So they consider that the anatomy of the uterus is important. We have to check it. But regarding the septum, the recommendation is only one small randomized controlled trial show no benefit of using hysteroscopic septum resection to reduce the rate of pregnancy loss. I don't know what they want to tell us. I don't know what they mean with this sentence, because if I read this, I don't know if I have to do the surgery or not, and in which patient I have to do the surgery or not. And the last confounder factor is the literature. Some years ago, a storm called the TRUST study came to our lives. And with this strong conclusion, you can see highlight. We recommend against septum resection as a routine procedure in clinical practice. And Human Reproduction sent an email to all the doctors in Europe with this recommendation. And everything changed. What have been done for years was wrong. The surgery of the septum was wrong. The retrospective studies, all the experience that we have, everything was wrong. But you know, when a paper like this arrived to our hands, sometimes we read just the title, the conclusions, and that's all. We know everything about the paper. So the title, does septum resection improve reproductive outcomes? That's the study question. And the answer is no. Hysteroscopic septum resection does not improve reproductive outcomes. That's all. And sometimes we have to read the paper. We have to read the full paper. And this paper is full of bias. Some short samples. Look, they include 80 women, 40 in the surgery groups and 40 in the expectant group. So everything has changed with the result of 40 surgeries. Okay, 40 surgeries in a period of 8 years in 10 centers. So there are centers, as you can see in this box. Those are the results of the centers from the Dutch center, from the Netherlands. There are centers with one patient. They include one patient in an 8 years period. And most of the centers, they have less than one patient per year. So think about the result of my surgery doing one lymphadenectomy every year. Probably the result will be terrible. Another important issue regarding this paper, they change the inclusion criteria 2 times during the 8 years period. At the beginning, they include only women with recurrent pregnancy loss. Then they extended to include women with subfertility, and 4 years later, women with 1 pregnancy loss or preterm birth. It is not common to change the inclusion criteria during a well-done randomized controlled trial. Second bias. But even more, they do not only change the inclusion criteria, but also the definition of the septate uterus during the study period. They change from the American Fertility Society 1998 classification to the ESG 2013 classification during the study. And you know that, as I told you at the beginning of this lecture, there are differences between those classification systems. Look at this. The right one is a septum for both, for American Fertility Society classification, for the ESG classification, even for me and for you, this is a septum, the right one. So there is no doubt about that. A complete septum is a septum, you know. The left one is a septum for the ESGE, but it is an arcuate, so let's say a normal uterus for the AFS classification, the old one, and for the new one, AS4M classification 2021. So if we check the results of do surgery or not, if it is better to do surgery or not, in the left one uterus, probably the result will be that there is no improving in the results if we perform surgery over an arcuate uterus. And probably in the TRUST study, they include most of the patients with this type of septate uterus. Indeed, in the TRUST study, they only had 3 patients with complete septum in the surgery group. Of the 40 patients, 3 complete, and the rest, 37, probably this kind of septate uterus. So they compared surgery as spectrum management of probably, let's say, arcuate of really subseptate small uterus. A strong letter was sent from doctors from all Europe to the editor of Human Reproduction against this paper. A lot of well-known names from different societies can be found there, and nothing happened. So they didn't give him an answer. So something that we have to do in the future is to do a good randomized control trial. We need it, a good one, based on the 3D ultrasound, probably with the same inclusion criteria, with the same classification system, with the same kind of surgery, because they did different kind of surgery, and checking that the result of the surgery is perfect. Not all the patients in this group have a second hysteroscopy or a second 3D ultrasound to check that everything was done in the right way. This recently 2 systematic review, that's what we're going to discuss later, and another one with Monica Krisman, they have been published. Both found a statistically significant reduction in the rate of miscarriage in women undergoing septum resection. And even more, I suppose you know this man well, Tommaso Falcone. He wrote this editorial recently in the JAME, stated that as for recurrent pregnancy loss, the observation of 2 systematic reviews support the concept that stereoscopic metroplasty for uterine septum can reduce the risk of miscarriage in women with a history of recurrent pregnancy loss. So I think that the important thing, and we have tried to do, is to questioning everything, even my lecture. We have to try to do our best for our patients. And you have, for me, this is a personal point of view, to follow different steps regarding the evidence that we have actually. One, use the 3D transvaginal ultrasound as first-line diagnostic tool. Second, in patients with recurrent pregnancy loss, we have to consult the patients to perform the surgery to have a better result. Third, patients with infertility or who are going to attempt an infertility treatment, we have to consult them that surgery will be benefit for them. And fourth, regarding the result of the meta-analysis that we're going to discuss, conceal to the patient that the resection of the septum may decrease the risk of adverse obstetric outcome. There is no evidence to recommend the hysteroscopic resection of a septum in a woman who have not yet attempted the conception. So we have no evidence regarding that. So the debate is open. I think that most of the centers we perform the correction of the septum in patients with recurrent pregnancy loss. We do the surgery of the septum in patients who are going to attempt an IVF treatment because they have infertility. And we do not surgery in a patient, a young patient, in which we find a septum and she is not going to, I'm going to attempt conception in the following years. So let's discuss about this and we'll see what's the discussion.
Thank you so much for your presentation.
Okay.
So before we
You're
open it up to the questions from the public, I'll just make a couple of points that I also thought I'll ask you. And then we'll see what Ekika and what others have to ask. So if you will notice that all the publications that are related or that are supporting hysteroscopic metroplasty or septum resection are always published by surgeons, and they are published in journals of reproductive surgery, or let's say AAGL journals, or you know what I mean. And all those studies which do not find support for septum resection are published by ART consultants who do not operate and are mostly practicing reproductive medicine. And it is usually published in, fertility, sterility, or human reproduction, or something like that. So that does bring in the factor that, of course, it matters who's operating, as you said.
Yeah.
In the Ricken RCT, I saw that with a few patients, they had one perforation. And we've been operating for so many years, and it's not common to get a perforation.
You know something interesting regarding this data from Ricken and from the Dutch.
Yeah.
You know that in Europe, every country has different regulations. And
yeah.
There in Holland, in the Netherlands, the surgery of septate uterus, it is not allowed by the law of the country. So
Yes.
they cannot do surgery except if they are inside a randomized control trial.
Okay. Okay.
So we do a randomized control trial about that surgical technique in a country in which it is not allowed to do that surgical technique. So it's nonsense.
Yeah. So
It's
they are not operating. They are not supposed to be operating unless they do it in an.
They are not allowed. They're not allowed in that country.
Yeah.
So patients from that country, they go to another country, maybe to Belgium or maybe to France, to perform the surgery, because in this country it's not allowed to perform this kind of surgery.
Yeah, I know that. So this is one of the things which will automatically create a doubt in the minds of even lay public, because the public, there is a bias because a surgeon who's operating is publishing favorable results, and ART. And the second thing also, which I noticed in the two things, like you pointed out in the RCT, is that they have taken uterine septum as a single entity. Yeah. Now, all of us know that there is nothing like a uterine septum. There are a million things. Like you said, it could be so many various types, and we just cannot take one entity as uterine septum. So the question they have asked in their RCT, does operating on an uterine septum improve reproductive outcome? Itself is a wrong question, because there is nothing called a uterine septum. There are so many different things, right? Wouldn't you agree?
Totally agree with you. Totally
Yeah,
agree
yeah,
with you.
yeah.
Totally agree.
Yeah, yeah.
So
And
the problem is bigger than we think, are more complex than reduce everything to septum to cut or not to cut. You know.
yes, yes. So we have a question in the chat before Ekika and Sunita ask any question. Now, somebody's asked, I think, a very relevant question. What is a subseptum? And what are its clinical implications? I think this is a question which really, another point that I wanted to make before you answer this question, where the surgeons were concerned, because the hysteroscopy became so commonly used amongst all general gynecologists, also for, as a diagnostic tool, doing metroplasty for subseptums, non-existent septums, deciding to operate on a septum while doing a hysteroscopy, all those things also became very common, isn't it?
Yeah.
So a subseptum, if you could explain what it is, whether we should be using this term anymore or not.
Yeah, I mean, for all the classifications that we have now regarding the different classifications, the one which I prefer is the latest ISRM classification, especially in this regarding septate or subseptate or partial.
The
septate
2021 one.
Yeah.
Yeah.
For me, that there is a problem in this classification that they don't have the dysmorphic uterus or the T shape, Y shape, I shape uterus. It does not include, but they consider that this kind of uterus is a problem of development, not a congenital malformation. So that's a reason. And this they talk about, sometimes it's difficult just to decide if 0.9 millimeters is arcuate and one is subseptate, and you have to, or you can do surgery over 1 centimeter, but not over 0.9. But for me, this is the best classification system that we have actually. It is based in the 3D ultrasound that for me is essential in the pre-operative diagnosis or evaluation of this kind of uterus. And I told the people who work with me usually that we do the surgery over pathologies, not over imaging. I mean, if I see a septum in a patient that I had a baby before, there is no recommendation to. It doesn't matter as if it is a complete septum. If you have a septum in a patient with recurrent miscarriages, I think that you have to do the surgery. So we have to combine the diagnosis and that size that the ISRM classification tell us, plus the clinical history of the patient. And that's what I have to make to decide if we have to do surgery or not to do surgery in those patients. So subseptate uterus needs surgery depends on the clinical symptoms, which is recurrent pregnancy loss or infertility. You know that there is an old study by Rafael Valle from USA. It's a really old study, and he stated that this is something that we know well. Not all the septum are related with bad obstetrical outcomes or problems. And he stated that it is around 20% of the septum are linked to any problem. Most of the septum have no problem. This is using the old classification, so they include complete and subseptate or partial septum, So
but
symptoms
I think
and clinical
we
symptoms.
should not use the term subseptate anymore, right? We should have a better diagnosis.
I don't agree with you, Sujata.
Yeah.
Louis, if the patient has a septum halfway in the cavity, maybe 14 millimeter, not reaching up to internal os, I will call that as a subseptum only.
No, so only two terms, partial and complete.
Partial or complete.
Yeah, that's okay. But what's most important for me, I feel, is septum cannot be diagnosed, as you were saying, Sujata, while doing a hysteroscopy.
Yes.
I feel you have a septum, you don't. Like how polycystic ovary drilling is not an intraoperative decision. It's a pre-operative decision that this is a PCOS patient. On table, you cannot say, oh, I feel your ovary is bulky. People drill the ovary for no reason when it is normal ovary. Same way, the septum, you cannot take a decision on table. It should be a preoperative 100% 3D sonography diagnosis, and you are posting the patient for a
But Sunita, in our country,
septum
many
resection.
people will not have access to 3D. So like Dr. Alonso, so what would you suggest would be the next best choice?
See, even in a 2D sonography, if you do the swipe, okay, you can make out very easily between the septum and the bicornuate. You got this shape is always a septum. You got this, maybe a bicornuate. Second important thing is the fundus is going to be one. So, but if those who don't feel or they are confused, they can do the saline sonography and they can decide on table itself. But I think, in 3D sonography now has become a necessity.
Yeah, but the expertise, not only the machine and the equipment is not there everywhere, smaller cities, the expertise is also not there. You need to have the person who will be able to make the, you just take a sweep, that's all right. But you also need to.
Every gynecologist now slowly, how we say, every gynecologist has to be a hysteroscopic surgeon. It becomes extension of your per vaginal. So I always feel per speculum, per vaginal, transvaginal probe, and then the office hysteroscopy.
Yeah.
It should become your extension.
Yeah, I agree with you, Sunita, in something that once when you arrive to the OR, you have to know everything about the patient and about the uterus, and you have to know you have to do surgery or not. The preoperative evaluation is essential.
Absolutely.
Absolutely. Before go to the OR. So if you have a 3D, I'm sorry, if you have a 3D ultrasound, of course, you have to use it. If you don't have a 3D ultrasound, you have to do your 2D with a sonohysteroscope, but you have to know before to the OR.
Taking, yes.
And that's essential. And I'm actually doing 3D ultrasound 10 years ago, but at the beginning I had no 3D ultrasound. And by 2D ultrasound, you can, if you do 2D plus hysteroscopy, when you have done a lot of patients, you know exactly what you are going to find inside just with your 2D ultrasound, because take a coronal view is difficult with the 2D, but you a sagittal view and then say the cross section and how the two cavities can be seen in the fundus. Absolutely. And you can even the size from the fundus to the mid cavity in the pointing with the cavity divide. So you can have a lot of information with 2D. Of course, if you have a 3D.
The outer contour of the myometrium or the fundus, probably you can 3D and MRI will tell us.
Yeah.
MRI, Sujata, 3D sonography will show you beautiful outer counter.
That's what I'm saying. 3D will be the best choice now. But only these two modalities will show us the outer contour as well as the inner contour. That's what I'm saying. Only hysteroscopy is also not going to show you the outer contour. So you'll also probably need a laparoscopic control.
Yeah.
So I have another very, million-dollar question, I feel. Supposing you find a patient who has not been attempting pregnancy, she's not a case of infertility, recurrent pregnancy loss, but you find a septum. Will you or will you not operate even a partial septum or
that's the most difficult question that you can.
Yes, but that is what most people end up asking. Are we going to tell her to no, you go try for pregnancy, once you get abortion only then I will operate on you?
Yeah. As I told you, I am biased.
Yeah.
So I know how time I spend in perform a surgery. I know my results and I know how the cavity will be at the end. But that's in my hands. So myself, same person, 15 years ago, I probably do not recommend any kind of surgery to that patient. Because I had the same experience, I had the same technique, I have the same tools, and I had the same results. Today, what I do is to explain to the patient the relationship between the septum and the bad reproductive outcome. And I counsel to the patient depending on different factors. It is not exactly the same patient that I don't want any kind of surgery. I'm 18 years old and I prefer to do nothing. Okay.
Let's move.
Or a patient with 41 who is going to start in Spain. You know that the woman, they try to get pregnant older, or not at the 80s or 20s. And if they came with a 41 years old, I want to get a baby, the first baby, and you have a septum, that's quite different. But in my hands, with my experience, I consult to the patient, and I think that the results are much better to decrease the rate of recurrent pregnancy loss. But depend on a lot of factors.
Individualize.
Yeah,
And see which
that's the
patient.
word. Concealing and individualize. Yeah, that's the
Sunita.
secret.
But you know what, Sujata? It will not happen with us at least that we saw the septum on table. We will do all the patient before we do the hysterolaparoscopy. We'll be doing their sonography. And this will be the pre-operative discussion with the patient that doing your surgery for this reason. But since you have a septum inside, I might as well operate because this will cause. And here the patient is conscious, awake. Her decision also plays a very important role. Even if I convince her and I counsel her that probably the evidence says that you will have a poor reproductive outcome or a subfertility, but she says, I will see when it happens, I cannot operate on her.
Yeah.
She doesn't give me the consent of it.
Right.
You see? Yeah.
So we have 2 or 3 questions in the chat box. Subseptum, I already asked you. Then we have Dr. Bharti Mishra from Berhampur asking, very meticulous analysis. Thank you, doctor. How many septum cases are with incompetence of cervix in your series? I guess what she's asking is once you've operated, once you've removed the septum, complete septum, or maybe even intracervical, do you have incompetence of cervix?
No. And even you know, one of the I mean the typical case is when we have a complete septum with double cervix, and even a vaginal septum. There are not so many cases of those. Actually, we have performed surgery over 19 of those patients. 19 is not is a good number, and we have had no problems at all of incompetence.
Okay, I don't know about Sunita. I think she will answer. But for me, in my practice, if I have cut the cervical septum also, which means a complete cervicouterine septum, I will give her a cervical encerclage when she's pregnant.
You know what, Louis? There are 2 issues in this. I was also of the opinion, or I may also, Sujata. But what I think, you know, because on the table, when you cut the complete septum, suppose from the fundus to the external os, and you will find that it becomes so patulous that your fluid also, you cannot maintain the intrauterine pressure. But what Louis says, I feel that after some period, the structure, the anatomy of the uterus, the musculature go back to its normal, and the tone of the internal sphincter comes back. So instead of blindly saying that I will put up the stitch, at 12 weeks, I would like to see her internal os, because now with the sonography, we can see the condition of internal os, the cervical length, and maybe at 16 weeks, one more sonography I will see to see if my sonologist, my fetal medicine consultant says internal os tightly closed, 3 to 4 centimeter long cervical length, there is no funneling, I may think of waiting, because now vaginal progesterone, we know they play a quite good role. There are so many publication and evidence has proved that cervical os tightening, stitch at 14 weeks, or putting the vaginal pessary, the results are equal as far as preterm labor is concerned.
Right.
So, practice. Maybe you think it.
Dr.
One thing I would like to say.
Yeah. Go on.
Louis, thing I would like to say is In septum, sometimes it's better to undercut than overcut to
Yeah.
avoid placenta ecreta or other placental problem. But at the same time, it's better to do second look hysteroscopy after you do the complete septum. What is your opinion?
I'm sorry, I couldn't hear you properly. Can you repeat the question?
Do you think in case of a complete septum, you would
Yeah.
like to do second look hysteroscopy?
Second look hysteroscopy.
Yeah. You know,
Because we all believe in undercutting than overcutting.
Yes.
yeah.
And sometimes your intrauterine pressure is so much that it may be overdue. So I always believe in, decreasing the pressure, seeing that I'm at the level of the cornu, but I always counsel the patient that I'll be doing your second look hysteroscopy and 3 to 4 weeks. I do 3D scan also, but irrespective of 3D scan, I like to see a second look hysteroscopy. What's your opinion?
Yeah. I usually, I actually am doing 3D scan at the beginning plus hysteroscopy, both things. Because
So you would do a
usually,
second look hysteroscopy.
yeah. 1.5 months after the surgery, because it's the way to know how the cavity is. And I have find no problem with adhesions with the technologies. We are actually using the mini resectoscope.
Okay.
I started using it around 6-7 years ago. We need no any dilation of the cervix, so that's easy to manage. It's a really accurate tool, and for the surgery. So what I do is 1.5 months after the surgery, I perform my 3D ultrasound and hysteroscopy. It takes no more than 10 minutes, 5 minutes.
Yeah.
And if there is a residual septum less than 1 centimeter, the classical study by Fidele that there is no implication in the reproductive outcome, and there is no recommendation of perform any surgery. Okay, it's all depend on how was the septum at the beginning, because if you had a septum of 1.8 and there is still remaining 1 centimeter, you did nothing.
Yeah.
But talking about complete septum, it is good to have that result.
Yeah.
If you keep less than 1 centimeter, you have to do nothing. You can check, you have to check that by 3D ultrasound is the way to do the measurement. With the hysteroscope, what they see is in that 1.5 months after the surgery, second look hysteroscopy, still all the area that we have cut is not totally covered by endometrium. And usually it is covered, totally covered in the septum and in other type of the surgery for uterine malformation 3 months after the surgery. And you see that the endometrium grows over that scar and cover the scar completely. So my recommendation is once the patient came 1.5 months after the surgery and I check that everything is okay, you can look for pregnant right now.
Yeah.
If you have embryos to put inside and you are waiting for an embryo transfer, you have to wait 3 months after the surgery, because it's the time that I have seen that remains to keep all covered by endometrium, and sometimes it's very difficult to get one good quality embryo. So we have to wait those 3 months at the time that the recovery of the cavity is completely normal. Yeah, but the second hysteroscopy is really important in cases of surgery inside the cavity, not for polyps, but if you have removed fibroids or uterine malformation or Asherman syndromes, or even retained products that you have to have a look. It takes no more than 5 minutes and you'll be sure that the cavity is perfect and you can go ahead trying to get pregnant.
Sunita, is it also your recommendation that we should wait for 3 months for an embryo transfer after dissection?
Complete. If it is a complete septum, Sujata, I wait.
You'll
Till
wait for that.
yeah, at least 2 months I wait, and second month I see the lining natural cycle.
And then
Luis, one more question.
another question from this point only. There are some people who believe in not cutting the cervical part of the septum.
I
What is
agree.
your opinion, Dr. Alonso? Do you do that? They
I-
only
I-
cut the intrauterine part and leave the cervical part.
I
From
always,
point of view,
yeah, after the study published by Parsenaf with a
Yeah.
good series, I perform always the cutting of the cervical part of the septum. Always,
okay.
except in cases you have, because sometimes what they check is the distance between cervix and cervix. Usually, what you have is a septum cervix, so
Yeah.
the os are closed. But sometimes what you have is two different cervixes with more than
Yes.
1.5 centimeters between them. In that case, I keep the cervix.
Yeah,
know?
yeah.
But
Because
if they are
we
close,
know that there are so many hybrid varieties also,
yeah,
which
Luis,
can have
let me
both
ask you-
elements of resorption as well as unification defects.
Would
So,
you like to do the septal resection or excision of a septum, Luis? What do you do?
Uh,
You expose
yeah.
Let's
What they do is the classic technique, just to cut the septum. You
Yeah.
know, the new current to remove. It is true that sometimes it's really muscular tissue, and when you finish, you can see muscle in that area that not depend also in the intrauterine pressure you are working with.
yes.
If you work with high pressure, usually the tissue go to the wall, and if you decrease the pressure, you can see how the muscle becomes. And sometimes if you have too much muscle, to remove that area, I have done sometimes, but it's not something that I
You
do
do see
routinely.
and make out because there will be some redundant septum hanging, so you feel that can be resected. So we
Yeah.
have some questions.
No. This is very big controversy. We all know Stefano and everyone about excision of the septum. Luis, I want to know what you do. Do you do the central cut
Yeah.
or do you excise?
No. Once you have the central cut till the fundus and you have finished, you see the scar in the upper area and the lower area with the muscle. And if you have too much tissue, what we do is you change to the loop and just to remove superficially that area. But it's not to remove all the septum. No. It's cut, and then if you have too much tissue, remove that area.
Okay.
You know, but I use the cutting
Okay,
technique.
I think we
In the
have some
middle.
more questions. Let us go through that. If a woman had 2 of first trimester miscarriages and then a spontaneous natural birth, now undergoing IVF for secondary subfertility and advanced maternal age, and discovered to have a complete septum, should we advise for resection?
Oh my God. That's
I wonder. So the woman had 2 miscarriages, then a natural birth.
Yeah.
And now much later she's having an IVF.
Yeah.
And then you find that she has a complete septum. I'm sure must have faced this situation.
Yeah, good question.
Should we advise
First thing
for
is
resection?
to ask to that woman at what age of pregnancy, how many weeks of pregnancy were those miscarriages, because we know that most of the cases of miscarriage associated with septum are not at the beginning, are not biochemical or at the beginning. They are usually over the 6 weeks or 7 weeks of pregnancy. So if she had the miscarriages at one biochemical and another at 6 weeks, and then the normal delivery, I will keep the septum. If those miscarriages they were at the 9 weeks of pregnancy and 12 weeks of pregnancy, and then the delivery, I will consider that those kind of miscarriages, late miscarriages in the first trimester, can be linked to the
And
Right.
one more thing, ma'am,
concealing to the
then
patient and to
it is
discuss
very
with discuss to the patient. But those are cases, oh my God, they're really difficult to
Yeah,
this
yeah.
patient had a preterm delivery of that live issue, then also it makes us, think that yes, we should obey. The of one normal live birth, it was on term or before term,
I
preterm.
think that is
So
not
that can also
mentioned.
decide whether we
Natural
should
birth,
cut the septum.
spontaneous natural birth.
Natural.
You know what, Dr. Sujata, what I feel is, even Luis, what I feel is sometimes the implantation might have happened on the lateral wall and the pregnancy continued. If the implantation has happened on the septum, she may land up in a missed abortion. So if for the elderly age group, you find the embryo, there is no harm in taking out the septum than just keeping the septum and landing maybe with the trouble. because I have one case like this at present going on, even with me. And I am planning her next month, the septum excision, before I do the embryo transfer. Yes, Sujata, now next questions.
Yeah. So anyway, the
You
same
want me?
that RCOG guidelines do
One
not
question I
recommend.
want to ask.
Yeah, I'm just completing that same
Yes,
question. 1 second, Ekika. So
Yeah,
the
sure, ma'am.
same question follows by saying that RCOG NIC guidelines do not recommend septum resection. So in recurrent miscarriages, so what to do? What is the standard consensus to cut a septum in ART failure cases? So recurrent pregnancy, sorry, recurrent implantation
RAF.
failure. Do we
Implantation
have a
failures.
consensus or any kind of a guideline?
RAF with septum. RAF with septum. So what to be done? And rest all the things if you
Dr.
find is
Louis,
normal.
Yeah,
And that's the only
Luis,
anomaly.
there is no consensus. There is no
Yeah.
consensus because the only guideline I know about this topic is that the one from ASRM, which is from
I think
7 years
Luis,
ago, and the one from the European Society, but the European one they say nothing, so they don't give you any recommendation what to do. So following the ASRM, what they state is that to perform the surgery after discuss the case with the patient, but there is no consensus.
And
Not at
Ekika
all.
has also posted another question, which is it
Range
just the
actually.
length or does the width of the septum also matter? I think even the cytostructure also is important, whether muscular or fibrous. So that is her question.
A thick
Yeah.
broad septum. A thick broad septum might not be complete septum or partial, but a thick broad septum. So
Yeah.
I mean, what is that you will decide in such cases?
Yeah, there is studies that they link the more muscular septum with second trimester contractions and premature delivery, whatever, and the most fibrotic septum with the miscarriage. So I think that it is important both. I mean, the every septum uterus works in a different way. And probably those with more muscular components is like, in the formation of the uterus and the embryology, whatever. If the problem is stopped before, you'll have more muscular component in the septum. And if we have more resorption of that area, you have less muscular part and more fibrotic tissue. And probably those are related with the miscarriage, and the other one with the hypercontractility of the uterus and the preterm delivery. So both are important.
The next question is, just vaginal progesterone is not helpful if internal os isn't tight enough to support the ongoing pregnancy. I think this question is meant for Sunita.
Yeah,
just vaginal
Sunita told.
progesterone is not helpful if internal os isn't tight enough to support the ongoing pregnancy. And the second part of the same person asking question is scissors versus resectoscope in a patient of infertility.
Scissors or resectoscope?
Yeah, which one?
I mean, for me, this is always a debate from those who perform hysteroscopy. If we use electricity, we make like a burn of the rest of the endometrium. Today, the systems that we have are really accurate. And when we perform the CAT is just in that area. So for me, and I use in the treatment not only of septate, but also the dysmorphic uterus, I have find no difference in the results when I use scissors or when I use electrosurgery, even in patients with Asherman syndrome. So for me, there is no difference at all.
Even with Asherman's, you would use a...
Yeah. And I'm using now a combined technique, because sometimes the Asherman syndrome, the problem is just to know where you are inside the cavity. Most of the cases, you can, the upper area and the corneal are free, most of the cases. So at the beginning, I use with the scissors, guide by ultrasound, try to find those ostia. If I find one ostia, I'm the happiest man in the world, because I know where am I, and then I know distances and so inside. Yeah. And once when I reach all that area in the upper part of the cavity, and if I reach both tubal ostia, then I change to the mini resectoscope, and I use it in the same way as I'm using in patients, for example, with dysmorphic uterus. Sometimes dysmorphic uterus, they are like a really tubular cavity with 7 millimeters from side to side. It's something similar to it. And then I changed to the miniresectoscope and I finished the surgery with the miniresectoscope, and the results are quite good. Quite good.
Yeah. But I think from practical point of view, if it's a thin fibrous septum, most often scissors works well. You can do most of the septums.
Yeah,
with
if a
the muscular and thick.
Yeah, that's true. If a fibrotic, you can use the scissor. You have not too much bleeding, and it's
Yeah.
usually easy, and just to touch with the scissor, the septum will open.
Right.
But most of the septum has some muscular area, especially in the upper area.
Yeah.
So you start easily with the scissor, but when you are in the middle of the septum, start bleeding, you see nothing, and you need or to do a selective coagulation of those vessels. And if you have any tool that can cut and to do a selective coagulation, this is better. What you have to do is don't use the coagulation for cutting the septum. You have to cut, pure cut, and you have to coagulate a selective coagulation with the needle. You can put the tip of the needle over the vessel and just touch the coagulation, and you'll have no damage. But don't use coagulation for cutting the septum.
Correct. Then another question is post-resection intrauterine device insertion or estrogen. Is there still any role?
Yeah, but I think there is a role for nothing because the studies they tell I use no any device inside.
Yeah.
No device
Either
inside. I still use estrogen because I don't know, because my mentor usually use, and it's a way to take this estrogen for 21 days and you'll have your period and come back after that period. But there is no evidence.
So you will give estrogen for every resection that you'll do?
Yeah.
Is that what I heard? Yeah.
21 days. Estrogen plus progesterone. Yeah.
Okay. So lots of questions are coming in. Risk of perforation in trust study, just one patient, Ekika is asking. If at all septum resection to be done, ideally whether to use scissor or electrocautery, I think we've answered. Up to what extent resection to be done? Give us some guidelines for our audience.
The extent of the resection?
Yes. How to decide when to stop?
You have to decide before the surgery. I mean, before go to the OR, you know if the fundal of the uterus is convex or flat, and you have to keep at least 1 centimeter of remaining myometrial tissue in the upper area, which is the normal width of the muscle in that area. So I always told to the patient who are going to perform the surgery, we will resect the septum, and I have to keep in the upper area between 1 and 1.5 centimeter of normal myometrium. Because if you reduce too much that area, you can have problems with uterine rupture during the pregnancy. And the objective is to resect the septum to go for a baby and to have a baby, and you'll get pregnant. So a remaining myometrial thickness in the upper area, at least 1 centimeter, and the recommendation is between 1 and 1.5 centimeters.
Can I say something? You know what I feel? See, you should know preoperatively the length of the septum and everything is 1.5. Now, when you are putting a hysteroscope in, you cannot see the myometrial thickness. So what I do in my practice is, I go on one side. Suppose there is a septum, I go on one side, I see the cornu, and with my monopolar, I give a white dot on the septum, the uppermost part. I increase the pressure, I decrease the pressure, and I see that that point is in line with that cornu. Then I go on another half, I see the cornu, and the highest point of the septum, I put again the white mark with the monopolar. I may cut little bit with monopolar and like this. What it helps me is, these are my end points. Then I calculate my septum with my telescope. If on a sonography, I have calculated 1.5 or 1.8, and more or less it's coming 1.8, I know that those 2 points are a valid endpoints, and I just go zoop, zoop, zoop. I don't have to then bother much.
Yeah.
Hmm. Very,
That's-
very good practical
That's a
point.
good trick, but
Yeah.
this is a really good trick.
So you,
but
before you start your surgery, you map your surgery, you decide how far, this is my upper limit,
yeah,
with that same pressure that when you've not cut, because once you started cutting, the pressure is going to
Absolutely, absolutely.
and then you'll
And
get more confused.
I made that white cut with my current, and I see that I'm in a line with the corner. I go on opposite sides, I do, and then it is very zoop, 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 zoop. I don't have to bother about
Excellent.
till I reach to that white point. Sometimes, maybe at the end, you increase, decrease, you want to give little lateral cut, that's okay. But this is the trick I always follow.
Excellent.
That's a good trick, but we have to send the message that this is a good trick that works for uterus with the fundus convex. You know, if you have in the fundal area of the uterus, you have an indentation.
Yeah, the hybrid
flat.
variety.
Yeah, be careful because the ostia are upper over that area, and you can keep that centimeters. If you go to that area, you can keep an area, a remnant diameter area of 3 to 4 millimeters in the upper area, and that can be a problem in the future. So, but that's a really good trick. Good trick.
Yeah. So I think we are, I have lots of questions and we are overshot our time by 15 minutes. Had a lovely discussion. Thank you so much. And I think I'll invite Dr. Sunita Tandulwarkar, who's our Vice President of ISAR. Can I have a CV, please, to give a very short summary? Riaz, are you all there? Although again, Dr.
Yes,
Sunita
ma'am.
does not need any introduction for the members of ISAR, but I love to talk about her. She's such a good friend of mine for so many years. And apart from all her achievements, I think the most extraordinary achievement has been India's first stem cell baby and world's first at the age of 45. And she's a passionate believer in stem cell therapy for regenerative medicine and regenerative gynecology as a whole. She has got many awards and she's authored 8 books, 29 publications, 60 keynotes and orations, and many international faculties as she has been invited, and many awards to her credit. The most, I think, best award has...
I think that's okay, Sujata, please. Thank you.
Foxy, Pride of Foxy 2020, and she is the current Vice President of ISAR. So give us a short summary of what should be our take-home message for, because every place, every locality, every patient, every doctor has to practice to suit their patient population. So what is our take-home message? To operate.
First of all, thank you so much. Yeah. Today I'm in the friends, Nandita, friends of us for 3 decades, the ISAR president, Sujata, with you, my relations of 2.5 decades. Everywhere we move together, and Louis, my beautiful, my fantastic global hysteroscopy friend. Because of him, I think I might have been introduced to another 1,500 hysteroscopic surgeons of the world. Ekika, the upcoming star of India. Thank you so much. So, first of all, I like this concept only of global. When Sujata comes and Nandita and Sujata, 2 minds come together, they will come out with such a interesting topics. 1 point and 1 hour discussion. What I loved, Luis, is first of all, I feel the septum has to be considered. You cannot neglect the septum. Now, whenever such meta-analysis or whatever the publication which has come, which says of trial, I love Luis, the way you read in minute detail, and probably you read because your opinion is totally against it. The septum need not to be treated or need not to be given attention, must have given a shock to you, especially if it is in a journal like Human Reproduction. The journal Human Reproduction, we know the acceptance rate is so low, and how they accepted and how the reviewers and everyone has published, I have no idea. But I love your idea that 40 cases over 8 years in 10 centers. I mean,
His rate was
Amazing.
0.37 per center per year.
yeah, yeah. See, look at the maths of Sujata. So I just love that. Even if I would have read all that, I think I would not have given such a minute attention to it, and I really appreciate it. And you made it very clear. I think Dr. Puntambekar, I don't know, Luis, you know him.
Yeah.
He is a laparoscopic surgeon of India, and when CA cervix not to be done by laparoscopy, the publication by AHL came. He fought like anything for that, and his publication came back recently that it has to be done by laparoscopy. So someone just taking septum for a granted, 100% it's not to be treated for subfertility or for poor reproductive impact is little unacceptable. And Sujata, I feel in whatever circumstances we are, if the smaller towns, they don't have the facility, the septum should not be treated unless you are a great hysteroscopic surgeon. It should be the advanced hysteroscopic surgery, anything, operative thing in the cavity, especially in a subfertile or a poor reproductive RPL patients. You have to understand that the first surgery has to be the best surgery. You can overdo, you can land up in perforations. So, and you can spoil her complete obstetric career. Forget about giving a better obstetric reproductive outcome. So, no surgery to be taken lightly. Pre-operative, your preparation, your understanding of the septum, not only in the length, breadth, thinking in your mind, simulating the surgery in your mind before you go in a OR. That is what practice I always do. I simulate the surgery. When I see the septum, because as Luis said, there are so many types of septums we have. So you need to simulate. We all know those which are broader at the fundus are little difficult than the one with the thin septum. So I think if you simulate the surgery, you know for what you are doing and you know how you are doing, absolutely you will optimize your results. So I think we have a wonderful, only one comment, someone when asked you that incompetent os is so big. You know what, when you now no more for a myomas, we just don't keep on resecting. Sometimes we enucleate the myoma. Sometimes I put the Collins knife and I just hook it out. And there is such a deep crater. Suppose if it is a type 2, 2.5 centimeter submucous myoma, when you hook it out, you find a beautiful thick crater of that myoma. You take out your telescope, wait for 30-40 seconds, and you go back in, you will find the crater disappeared. The myometrium contraction happens. Now, Luis says in his studies, he is not found incompetent os even when he has cut the complete septum. And my saying is, that is because the myometrium, the internal sphincter, at that time you feel it is so loose, but it reforms, it restructures. And probably it gains because we have not done any damage to the internal sphincter.
To the
I
extractor,
also
yeah.
agree about the cervical septum part. If the cervical septum and if the two cervix are next to each other, it's very easy. You cut it out. It becomes a patulous cervix. After 2 months, you put the speculum. You find that it is not so much patulous as you had left it. And if the two cervices are on two directions of the fornix, then it's very difficult to cut that. But usually it is associated with vaginal septum also.
Yeah.
And I make a habit of cutting the vaginal septum for those patients. So I cut vaginal septum, I cut uterine septum. I may not cut only that part of a cervical septum where the services are away. Thank you.
Thank you so much.
Wise words.
Thank you so much.
Okay.
So I think we are
Thank
at the end of our global.
I'm
Uh,
sitting at
chapter
the airport
seminar.
waiting to be checked in.
And dear delegates, thank you all for joining. Next month, we have another one of these webinars with Carlos Simon, again from Spain. And we are going to discuss the lab of 2029. So
Okay.
that should be another webinar to look forward to. Thank you very much. And it was a great interacting with all of you. Thank you, Louis. Thank
Okay,
you.
thank you
Sita.
to all of you.
Thank you.
you,
Thank you very much.
Nikita.
Thank you,
Thank you.
Louis. See you next month.
See
See
you
you.
next month. Bye. Bye.
Thank you.
Thank you very
Riaz
much
and Trupti.
for having me here.
Thank
Thank
you.
you, Dr. Sujata. Thank you, ma'am.
Thank you so much, ma'am.
Bye.
Thank you.
Bye. Bye.
Bye, everybody.
Bye.
Good night.